Okay, let's dive into this. We are going to rapidly conquer 5 major anatomical buckets today. We'll start with femoral hernia fundamentals, move on to ventral hernia varieties, then cover pediatric and congenital defects, hunt down some rare and specialized hernias, and finally, we'll wrap up with mesenteric abnormalities. Section 1, Femoral Hernia Fundamentals. We're beginning our anatomical descent right in the groin. Specifically, we are looking just below the inguinal ligament, which is exactly where that notoriously high-risk femoral ring resides. Let's break down the actual boundaries of that femoral ring, because the anatomy tells the whole story here. Superiorly, you've got the inguinal ligament. Inferiorly, the pectineal or Cooper's ligament. Medially, there's the lacunar ligament, and laterally, you'll find a thin septum separating it from the femoral vein. Now think about this. 3 of those 4 boundaries are rigid, totally non-dilating ligamentous structures. Because this ring absolutely cannot stretch, it perfectly explains the dangerously high rate of obstruction and strangulation we see with femoral hernias. So you're faced with a classic clinical dilemma. Is it an inguinal or a femoral hernia? Well, the absolute key clinical differentiator when you're examining a standing patient is the relationship of that bulge to the pubic tubercle. It's that simple. Inguinal hernias are going to present above the pubic tubercle. Femoral hernias, on the other hand, present below and lateral to it. You definitely want to burn that specific spatial relationship into your memory. Now, what's really fascinating here is the concept of a Richter's hernia. Because the femoral defect is just so incredibly narrow, sometimes only a tiny portion of the bowel wall actually gets pinched inside it. The rest of the bowel lumen, it remains completely open. This means early on, the patient entirely lacks those classic obstructive symptoms. It can actually mimic simple gastroenteritis at first, before silently and very dangerously progressing to peritonitis. Moving on to Section 2, Ventral hernia varieties. Let's shift our focus up to the abdominal wall. Now, while incisional hernias are definitely the most common in this particular group, the core surgical management principles are going to unite them all. When we go in to repair these ventral defects laparoscopically, we frequently use a technique known as IPOM. That stands for intraperitoneal placement of mesh. But here's the catch. If you just throw a standard mesh directly inside the peritoneum, the bowel is going to aggressively stick right to it. So the logic here is simple, but literally life-saving. We use a specific PTFE mesh for IPOM. That material gives the mesh a non-stick surface, safely navigating the risk of the bowel sticking directly to it, which would otherwise form disastrous adhesions or fistulas. Let's rapidly contrast 2 periumbilical cousins. An umbilical hernia comes directly through a wide umbilical ring. This gives you that classic everted outie belly button, and because the defect is nice and wide, it rarely ever strangulates. But a para-umbilical hernia, that pushes out just adjacent to the umbilicus through a really tight defect, creating what's called a smiling umbilicus. And that narrow defect is a huge red flag. It mandates immediate surgical intervention because the obstruction and strangulation risks are incredibly high. All right, Section 3, Pediatric and Congenital Defects. Let's move on from adults for a minute and step into the neonatal intensive care unit. We're going to look at some key visual differences and immediate critical care management protocols for newborns. Omphalocele versus gastroschisis. So the absolute crucial point here is whether or not there's a protective peritoneal covering over the herniated bowel. In an omphalocele, the bowel herniates straight through the umbilicus, but it is safely covered by a peritoneal sac, though keep in mind it's highly associated with other syndromes. In gastroschisis, the defect is adjacent to the umbilicus, and the bowel is completely bare. It's exposed directly to amniotic fluid, leading to a massive risk of severe inflammation and perforation. Now, you can't just shove all that exposed bowel back into a tiny newborn's abdomen. You'd cause fatal abdominal compartment syndrome right then and there. And this brilliantly illustrates the staged reduction technique. Step 1, you create a cylindrical mesh silo right over the defect. Step 2, over a period of weeks, you gradually reduce that silo's height. Step 3 is slowly pushing the bowel down to the rectus sheath level. Finally, step 4, safely close the abdomen only once it's actually accommodated that volume. Okay, imagine a newborn in severe respiratory distress, and they're diagnosed with a congenital diaphragmatic hernia, or CDH. I want to pose a really critical, life-saving question to you right now. Why is bag and mask ventilation strictly contraindicated in these infants? The answer is purely mechanical. When you pump air through a mask, air inevitably goes right into the stomach. In CDH, that stomach has already herniated up into the thorax. So the pumped air drastically dilates that intrathoracic stomach, which instantly compresses the already underdeveloped lungs and rapidly worsens their pulmonary hypoplasia. And since pulmonary hypoplasia is the ultimate cause of death here, this mandates immediate intubation and ventilation via intermittent positive pressure ventilation instead. Let's quickly differentiate the two main types of congenital diaphragmatic hernias while we're on the subject. The Buch-Deleck hernia is by far the most common. It accounts for about 70% of cases, and it occurs on the left posterolateral side. The Morgagni hernia is much more rare, sitting on the right and anteromedial. Oh, and a high-yield surgical pearl for you. Repairing these requires a very distinct circumferential incision right over the diaphragm itself. Section 4. Rare and Specialized Hernias. We are officially entering the zebras section of this explainer. We are going to hunt down those high-yield, eponymous, and highly testable rare specialized defects. Let's efficiently map out the distinct borders of the two highly testable lumbar hernias. Picture the inferior triangle of Petit sitting right on the bottom at the iliac crest. Then you have the superior triangle of Grinfeld, which is bounded at the very top by the 12th rib. Notice how the latissimus dorsi and external oblique flank Petit on the inside and outside, while the sacrospinalis and internal oblique frame Grinfeld. You really want to walk this anatomical map into your memory. Now meet the obturator hernia, classically known in the wards as the little old lady's hernia. It carries a massive strangulation risk because it squeezes right through the extremely narrow obturator canal. And because it's deeply hidden under the pectineus muscle, you are rarely going to feel a palpable swelling. Instead, you have to rely on specific neurologic exam signs to unlock the diagnosis. Look for the Hauschip-Romberg sign, which is shooting pain down the medial thigh, and the Hannington-Kiff sign, which is an absent adductor reflex. Next up is the Spigelian hernia. This one is a sneaky inner parietal hernia hiding directly between the muscle layers of the abdominal wall itself. You'll typically find it below the umbilicus, but above the arcuate line. Because the hernial sac remains completely trapped beneath the external oblique aponeurosis, it's notoriously hard to palpate. Unfortunately, that means it's often caught perilously late, usually only after obstruction or strangulation has already occurred. Madel's hernia is honestly terrifying. It's a W-shaped hernia containing multiple loops of bowel. The trap here, the highest risk of fatal strangulation, actually occurs secretly in the intra-abdominal segment, the middle part of the W that you can't even see. If a surgeon just opens up and inspects the external sac, they'll see perfectly healthy bowel and could disastrously miss the gangrenous segment hiding silently inside the abdomen. And finally, Section 5, Mesenteric Abnormalities. To completely round out our clinical matrix today, let's step away from the abdominal wall altogether and analyze fluid-filled cysts that develop deep within the mesentery itself. Let's contrast two specific cysts, chylymphatic cysts versus enterogenous cysts. Chylolymphatic cysts contain clear fluid and, crucially, they have an independent blood supply. This means they can be safely treated with simple enucleation. Enterogenous cysts, however, contain turbid fluid, and they actually share their blood supply directly with the bowel. This vascular anatomy dictates the entire surgical management. Treating an enterogenous cyst absolutely requires a full bowel resection. When you're examining a patient, you want to look for the classic Tillow triad to identify these cysts. First, you'll see a periumbilical swelling. Second, that swelling moves at right angles to the mesenteric attachment, but strictly not along it. And third, you'll find a transverse band of resonance on percussion. That band of resonance happens simply because the transverse colon is stretched directly over the underlying fluid-filled cyst. Well, we've covered a massive amount of clinical anatomy today in a very short time, so I'm going to leave you with this provocative thought. If a single millimeter of ligament in the femoral ring, or a shared blood vessel in a mesenteric cyst, can dictate the difference between a simple, safe repair and a massive, life-altering bowel resection, how is this immense power of anatomical precision going to change your diagnostic approach on the wards tomorrow? Keep learning, stay focused, and we'll see you in the next explainer.